Let's do DIC, which is something that you haven't done before. How would you define DIC?
So DIC is a consumptive coagulopathy, which typically involves the fibrolytic and also the coagulation cascade. It's typically seen with microthrombi, and a blood picture for this patient could also include seeing fibrinogen degradation products. The pathophysiology for DIC would be the use of the...
What's a clinical presentation?
The clinical presentation for patients with DIC would be typically associated with either hemorrhage sepsis, or after a massive blood transfusion. They typically can present with multi-organ failure and bleeding, mainly from peripheral sites such as the cannula.
What are the lab findings?
The lab findings for DIC would be typically based upon a blood. Patient would be metabolic acidosis. They'd also present with increase in PT and an increase in fibrinogen degradation product.
What are the causes of DIC?
The causes for DIC are widespread. The main ones are number 1, sepsis, number 2, massive blood transfusion, and number 3, hypothermia.
What's the treatment?
The treatment for DIC would first of all be involved in speaking to hematology, and then the mainstay treatment would be frozen plasma and cryoprecipitate, and also platelet or blood transfusion.
You mentioned that you're going to speak with hematology. Is there anyone else to speak with?
Yes, I would also like to speak to the medical team on call, hematology. I'd also want to speak to ITU and HDU, as the patient might need further support as well following multi-organ failure.
And how are platelets formed in the bone marrow?
Gosh. So platelets are formed from the bone marrow from, I think it's megakaryocytes.
What's the function of platelets?
And the function of platelets is to allow hemostasis, allow adequate transfusion of blood to the peripheral sites and oxygenation of tissues, but its main role is in that of coagulation.
Okay.
The indication for platelet transfusion, number 1 would be patients on cardiopulmonary bypass, number 2 would be sepsis or massive hemorrhage, and number 3 would be patients with a platelet level less than 5 times 10 to the power of 6.
And what's what's the hemostasis definition?
Hemostasis can be defined as the body's ability to auto-regulate in response to external stimuli.
What's the difference between primary and secondary hemostasis?
I'm not too sure. Can I move on to the next question, please?
What are the stages of hemostasis?
So the stages of hemostasis would be 1, tissue injury or insult. Number 2 would be the activation of thromboxane A2 and a platelet. Number 3 would be a platelet plug formation. Number 4 would be the activation of the internal and external coagulation cascade, then into the common cascade, forming a stable fibrin clot. And then number 5 would then be resolution of, or 4 or 5 would be resolution of the hematoma.
What are the measures to reduce intraoperative blood loss?
So the measures to reduce intraoperative blood loss would be 1, anesthetic can lower the blood pressure. Number 2, we can give also the use of diathermy or pressure packing on certain wounds. And number 3 would be to reduce the patient hypothermia, so you can give intraoperatively IV warm saline and also the bear hugger. And other things can be used such as TXA on induction of surgery or during surgery as well.
How would you define massive blood transfusion?
Massive blood transfusion is losing 40% of the blood volume in 4 hours.
Is that an adult or a child?
That would be in an adult.
What about a child?
I'm not too sure. Can I move on to the next question, please?
What are the complications of massive blood transfusion?
So the complications of a massive blood transfusion would be 1, an acute reaction such as fever or pyrexia. Number 2 would be TRALI, which is a transfusion-associated lung injury. Number 3 would be multi-organ failure. Number 4 would be associated with metabolism. So citrate is typically used in massive blood transfusion, which causes the chelation of calcium, so you get reduced calcium. And then number 4 would be urea and electrolyte imbalances such as hyperkalemia leading to arrhythmia.
What are the early post-operative complications in triple A repair?
So the main one here we're worried about are the branches of the abdominal aorta. So typically you get ischemia either of the lower limbs, of the spine, and of the bowel. So you can get ischemia of the bowel. Number 2 would be that of abdominal compartment syndrome. And number 3 would be also sometimes, depending on the graft used, you can get a continuous leak or an endo leak post-operatively down the line.
Well done. Massive blood transfusion in a child?
I'm not too sure.
What difference between primary and secondary hemostasis?
So primary hemostasis would be where there's a direct injury to the blood vessel or vessel wall, and secondary hemostasis would be formed by external injury or trauma to the vessel, but I'm not too sure.
That's fine. I think let's go, because there are a few things to mention. So definition of, I would have stopped at just the definition. I think you went into some of the pathophysiology, some of the clinical presentation, and even some of the lab findings. I would just stop. It's the first line. So it's a pathological consumptive coagulopathy due to activation of the coagulation on the fibrinolytic system. That's it. So it's actually, this definition is from Pathoma. I'm not sure if you came across Pathoma before. It's a really good source for pathology that is used for USMLE. It's every word, literally every single word is important in that definition. So it's pathological. That means it's not physiological. It's abnormal. And it's consumptive coagulopathy. The patient will have coagulopathy and will have activation of two systems. They will have blood clots because it's coagulation, and they will have also bleeding because it's fibrinolytic. All right. So the definition gives you literally everything. All right. And it's very expressive. So you don't have to further explain it. All right. So you just stop there, and that's absolutely enough. The pathophysiology of I think, again, here you went into some of the causes, which is okay. It's not a problem. But here it's talking about what's actually happening in this pathological process. So you have activation of the coagulation cascade. What will lead to formation of multiple microthrombi?
Yes.
These will be lodged into the blood vessels on the small capillaries. And this can lead to ischemia and then
infarcts.
And because you're having lots of microthrombi all over the body, this will lead to consumption of your coagulation system. Platelets will be gone. All the factors will be gone. So you will have thrombocytopenia, and they will have all the factors are lost. So any simple injury that you have will lead to significant bleeding. If you have a urinary catheter, it will be full of blood. If you have a cannula, it will be, you will bleed from your nose. You'll bleed from all the orifices. You'll have lower GI bleed. You'll have bleeding from everywhere. All your orifices will be bleeding. So, and this bleeding happens later on in the pathology. It's not too late, but it happens after having the microthrombi and the coagulation activation. So this is how you need to present the pathophysiology. And instead of talking about the causes, because there are multiple causes that can lead to DIC. Clinical presentation, as we said, microthrombi that leads to ischemia and infarction, and bleeding from everywhere, including the IV sites and also mucosal surfaces, all your orifices, etc. The lab findings, you've said it correctly. I prefer saying a few things will be decreased, a few things will be increased, and then the MAHA, or the microangiopathic hemolytic anemia. All right. Yeah. So you have platelets and fibrinogen are decreased. The F dimers and D dimers will be increased, and PT was PTT. The causes, you've mentioned this very well. So you have the hemorrhage, the blood transfusion, sepsis, the snake bite, the obstetric complication, the treatment. I think you should have classified it into this, so we can do transfusion, supportive care, and you need to focus on supportive care because this is your main treatment: oxygen therapy, fluids, and blood transfusion, anticoagulants, etc. Right? So you need to focus on your supportive care because this is the main way that you treat the patient. Go to involve. I think that was okay. There is another question. Indication of platelet transfusion. What you said was correct, but I would like to classify this into two things. So you want to classify it as patient who have platelet loss, they're actively losing their platelets, and patients who have thrombocytopenia. They have platelets, but the number is decreased. So the platelet loss, which either it's overconsumption or platelet dysfunction. Overconsumption, that happens in something like DIC and something like ITP.
Thrombocytopenia.
Also, dysfunction, that happens with something like aspirin. Patient are on aspirin or clopidogrel. All right. And then thrombocytopenia less than 50, 10 power 9. All right. Hemostasis. I asked you to define hemostasis, not homeostasis. You define homeostasis. So hemostasis, this is the process that will lead to formation of a platelet block formation. Right. So this is your coagulation cascade.
Oh my.
So you defined homeostasis. We've made a good definition for homeostasis, which I think it's a definition somewhere else. I don't remember what scenario, but it comes in the exam as well. All right. primary and secondary, and this is, you're a bit confused about this. So primary hemostasis, this is the formation of the platelet block formation, but it's very weak, and it's mainly due to interaction of between the platelets and the endothelial injury. You've mentioned initially when I was asking you about the stages, you've mentioned tissue injury. It's not necessarily a tissue injury, it's an endothelial injury. So the primary is the platelet block formation. It's weak, and it's due to interaction between the platelets and the injured endothelium due to thromboxane A2 activation, as you mentioned. And then secondary hemostasis, it's a formation of a platelet block with the meshwork, so it's very stable, right? Yeah. It's mediated by the whole coagulation cascade with all the factors. The stages, I think you mentioned it well: endothelial injury, vasoconstriction as a reaction, platelet adhesion, platelet degranulation, and then platelet aggregation, and then platelet block formation, and then your coagulation cascade will comes in, intrinsic and extrinsic pathway. So you need to have, this is specific buzzwords to mention in the exam. Correct. If you literally mention just a single words, you say endothelial injury, vasoconstriction, platelet adhesion, platelet degranulation, platelet block formation, coagulation cascade, or weak platelet block formation, coagulation cascade, intrinsic and extrinsic pathway, and the strong or secondary hemostasis or strong platelet block formation. The measure to reduce blood loss intraoperative, you made a good answer, all right, but I think there is a way to improve it. I think there are a few things to do before the operation, and things to do during the operation, and things to do after the operation.
So pre-op, intra-op, and post-op.
So in your pre-op, you need to work out your patients quite nicely, right? So you need to get all the needed bloods, make sure you check their coagulation, take good history, and make sure they're not in any anticoagulant. And if they're any anticoagulant, try to reverse it. Look if they have any sort of coagulopathy. Discuss with hematology before and get a plan from them, all right? And inform the team, discuss with the anesthetics, and discuss the risks to patients, etc. etc. So these are all factors to consider, reducing the intraoperative blood loss, and arranging blood or blood products if required before the operation. After you've done all of this, intraoperative, you need to plan things. First of all, obviously try to use hemostasis from the way in, starting from the skin and subcutaneous tissue, etc. You would use the monopolar and the bipolar. You would use the cell saver if required. The patient position is important as well. The using packing and the surgical products such as Surgicel, Flow Seal, and etc. can be used. And anesthetic colleague can help you with giving thromboxane using the bear hugger, and also only expose the areas that are required from the patient to avoid hypothermia.
So this is, because this stem also is attached to the hypothermia stem in AS, isn't it?
Correct. So this is a post-operative, adequate coverage to the wound. You can use bandage if required. So it depends what operation you're doing, but you can use bandage if required. You can use a drain as well, which help evacuating all the spaces and then packing your wound, etc. Right? So these are I think it's just a better way to give an answer to that question. I know here I literally mentioned just a few points, but I think this is how I would answer it in the exam: pre-operative, intraoperative, and post-operative. Massive blood transfusion in an adult, you mentioned it correctly, which is 1 blood volume in 24 hours or more than 50% in 4 hours. In a child, it's a bit different, right? So it's calculated per kg, more than 40 ml per kg at any given time.
Okay.
So at any given time, more than 40 ml per kg, that means that this is massive blood transfusion in a child. This was okay, and this was perfect, actually. So just a few learning points from here. The pathophysiology, the hemostasis definition, the primary and secondary hemostasis, and the indication of blood transfusion, as we talked about it.
Nice. No, I think you've added more questions to the stem from other previous videos, so it's more up to date than the one that I've actually learned, which has been really useful, actually. So thank you.
Probably I need to redo it because I think the video is a bit old now. It's about 1 or 1.5 years old. I think you've done more